great it is to see everybody smiling. Now we're on streaming. That's good.
Okay, we're good.
Okay, good.
All right.
All righty. Go ahead, Senator.
All right. Good morning, everybody. We're going to start the Friday, August 4th Appropriations and Human Services public hearing. Are there any remarks by chairs?
You're reverbing.
I'm not. It's somebody up here that had their computer on. I think they already turned it off. Representative Walker, anything?
No, ma'am. I've been talking up a storm, waiting for everybody to get on. So I'm good now.
Okay. Senator Berthal.
Good morning, Madam Chair. I'm all set. Thank you.
Representative Nuccio.
Good morning, Madam Chair. No remarks this morning. Thank you.
Senator Lesser.
I'm good, Madam Chair. Thank you very much.
Representative Gilchrist.
I'm good as well. Thank you so much, Senator.
And the ranking members of Human Services.
Ready to roll, Senator.
All right.
Good morning. Thank you for having me.
Very good. We will have, I'm trying to figure out exactly what we're going to be doing today. I guess we're going to have
Some help.
I don't know.
I can. We're going to be.
It's a bad day, I guess.
Senator Austin.
Start with the speaker order. We're going to have Commissioner Sheff, if you and your team want to come up.
So what we're going to do, Madam Chair.
Thank you.
You're welcome. Commissioners Barton Reeves, Sheff, and Navarrete are going to come up to the witness table. And they have a joint presentation that they're going to give to the committees. They have here in room 2C, they have staff to support them and to answer any questions that they may need some help with. The staff will be sitting at the other staff table in room 2C, so they'll be rotating through there. And they're going to start with a PowerPoint presentation, Madam Chair.
Go ahead. Commissioners in total. The floor is yours. Let's get this moving along. See if we can roll it along quickly before the rain comes.
All right.
Good morning. Good morning, Senators Austin and Lesser, Representatives Walker and Gilchrist, and honorable members of the Appropriations and Human Services Committee. My name is Andrea Barton Reeves, and I'm the Commissioner for the Department of Social Services. In accordance with the provisions of Section 17B8 of the Connecticut General Statutes, we're here today to seek your support and approval for various amendments to all of the 1915C home and community-based Medicaid waivers. As the single Medicaid agency, we have administrative oversight over all of these waivers. I am pleased to be here today with Jordan Sheff, Commissioner of the Department of Developmental Services, and Nancy Navarrete, Commissioner of the Department of Mental Health and Addiction Services, as well as their teams to assist in any questions that you might have. So maybe start the presentation. All right, and if we may move to the second slide, please. So to offer a quick recap of why we're here today, our state already has Appendix K waivers, which are essentially waivers that were designed and promulgated during the COVID-19 and public health emergency crisis. Those waivers gave us an opportunity to expand a number of services, many of which have been of great benefit to the people in our state. But these waiver applications that we're here before you today will allow us to make many of those waivers permanent consistent with our ARPA Home and Community-Based Services Reinvestment Plan that we came to the committee and spoke about in January. Now, we have selected supports and services because these are the ones that we believe have delivered the greatest degree of services to and supports and value to our Medicaid members, to our elders, and to other members of our community. So the waiver amendments are actually due to CMS in 90 days, and we would like to get them submitted by August 11th. What I'd also like to say is we have been working on these for quite some time because the CMS process is quite lengthy. And the last step is to come before you and ask for your review and approval. So we are here today for that reason. Next step, next slide, please. There are 10 waivers. You only see 9 bullets because we've combined acquired brain injury waivers 1 and 2, and you can see them there. We are talking about our community, our home and community-based waivers for our elders, personal care waivers, acquired brain injuries 1 and 2, autism waivers, what is commonly known as the Katie Beckett waiver, mental health, comprehensive supports, individual family supports, and employment and day services. What is actually really unique and I think, I'll just say this anecdotally, a really beautiful thing about this is that we have all of our health and human services agencies working together to determine, based on our experience, what really provides supports for the people in our state. And we've been able to come together and pull these waivers and make a single application for all of them. Next step, please. Next slide, please. Sorry, thank you. So because there are many of them and they are quite complex, I actually have the notebook that's about 3 inches thick. It's about 2,000 pages, but we thought a summary would probably be helpful. And here is where we have a simple chart that gives the specific waiver, the services that we will be supporting through the Appendix K, and some new services actually we found as a result of delivering the services that we'd also like to ask you for your approval. And our very, very talented and capable teams at supporters will come and provide more details as to each of these. So next, I'd like to turn the microphone over to Commissioner Sheff so he can speak directly to the DDS waivers.
Good morning, Jordan Sheff, Commissioner, Department of Developmental Services. I'm joined at the second table by our CFO, Nick Gerard, who will help me when I stumble or when you have questions I can't answer. And thank you for the opportunity, and thank you, Commissioner Barton Reeves, for the introduction. As noted by Commissioner Barton Reeves, we have 3 waivers. The renewals for these incorporate what we had learned under Appendix K that was working for us that we wanted to carry forward through the ARPA HCBS spend window through March of 2025. You previously approved all of these waivers during the Appendix K. There's nothing new. There are no changes. And I will highlight the 9 areas that we're looking to incorporate into this waiver and take any questions you may have. So the 9 areas that are important to DDS and to our constituents to incorporate in this waiver include stabilization payments for qualified providers, payments for qualified provider types to modernize billing processes and systems, incentive-based outcome payments to residential or day providers covered under the waivers that submits a transition plan for anyone from a congregate setting to a more integrated setting, incentive-based outcome payments to qualified residential or day providers covered under the waivers that transitions the participant from congregate residential settings to more integrated community-based settings, incentive-based outcome payments to any qualified residential or day provider covered under the plan that completes certain objectives as part of the approved transition plan, incentive payments for DDS qualified providers that complete the National Core Indicators, IDD, Intellectual and Developmental Disability State of the Workforce Survey, an incentive payment for any DDS provider for each job coach or job developer that completes specific trainings, an incentive payment for DDS qualified provider that has 1 or more of their staff complete certification in to become assistive technology professionals, and temporary or enhanced rate increases for specific employment and residential waiver services, authorizations covered under the specific waivers. We're confident that these expanded opportunities provide the financial fortitude to allow DDS individuals, the providers that support them, to help those individuals live and work in the most integrated setting of their choice. And I think that's the summary as I'm looking at this, and available to take any questions that you may have.
Oh, we're not going to do questions until you're all done.
Yep. So it just
Just makes more
in
sense.
summary, and to be clear, we use these incentives during this spend period because of our commitment to live within the appropriation, and this allows us to utilize federal funds to try and change and transform the system in a program we call Supporting Transformation to Empower People, and we can provide a lot more information about that. And with that, I will hand it back to you, Commissioner, or to Commissioner Navarrete. Can you get to that mic? Okay.
As long as you can hear me. Can you hear me okay?
Yep.
So good morning. I'm Nancy Navarrete. I am Commissioner of the Department of Mental Health and Addiction Services. And I have with me today Erin Levitt-Smith, who is Director of the Mental Health Waiver Services. So I appreciate the opportunity. Thank you to come before you today to express support for several changes to the mental health waiver. So we're proud to operate this waiver in collaboration with Commissioner Reeves and allow for the care in the least restrictive setting and collaborate with our sister state agency, Department of Social Services. As a brief refresher, this important program facilitates person-centered recovery for eligible adults with serious mental illness. So they meet nursing home level of care. And this program is essentially a discharge and diversion program from nursing home level of care. We provide an array of home and community-based services that emphasize intensive psychiatric rehabilitation to allow individuals to live in the community and avoid institutional level of care. These services include peer support provided by individuals trained and certified in rehabilitative care with lived experience relating to recovery. The majority of expenses are on recovery assistance services, which combine the job functions of homemaker, personal care attendant, respite worker, and companion for folks. The focus of the work centers on teaching, coaching, cueing, training individuals to increase capacity for recovery and independence. So turning our focus to today's hearing and our request, you have already heard the background on transitioning the temporary authority afforded by the public health emergency to the permanent waiver authorities now that the public health emergency has ended. In the mental health waiver, as in all other waivers before you today, DEMIS proposes to maintain the increased provider rates, as well as allow for the provision of services virtually if it's necessary. So that would be the exception rather than the rule. These changes were previously approved by your committees as well as CMS. Additionally, want to highlight two other proposed changes not related to the end of the public health emergency. So updating terminology in the waiver. So we changed the language a little bit so that we can provide residential services to individuals that live in RCHs or residential care home settings. We think it's be very supportive for them, and a lot of folks with a serious mental illness utilize that as a place to live. Expanding the types of the second is expanding the types of professionals that can provide mental health counseling services by including professional counselor associates, licensed masters, social workers, licensed marital and family therapists, and marital and family therapist associates. So in this workforce environment, it's good to be able to recruit as many different kinds of master's prepared individuals to offer counseling in-home services. These changes will allow DEMIS to continue to successfully operate this program, and we respectfully request your approval. Thank you.
Commissioner, next, are you up next?
Mike, I will provide an overview and then I will ask my staff to join me. So with respect to the DSS waivers, we have quite a few of them. We actually have the majority of them. And these will allow several things to happen, not the least of which is to continue to allow us to deliver critical services in the community that we've seen have been of great value during the public health emergency. And some of our changes include expanding the definition of assistive technology, training and counseling for unpaid caregivers, which is a significant segment of caregiving in the state, continuing the delivery of what we have come to find out are evidence-based home care delivery models, particularly for elders, and some value-based payment models and value-based payments to improve outcomes for Medicaid members. So we will start by talking about the home and community. I'm sorry, next slide. So I'm not good at the cues. I apologize. Okay. We will start by talking about the home and community-based waivers for elders. And to do that, I'm actually going to ask Carrie Feilich to come and Or is it Amy? You can come together. I'm asking Amy
Why don't
Dumont
you
and
come
Carrie
over to that
Violet.
table right over there. That way we can keep the commissioners
Thank you.
there. And you can turn on that mic right there to speak. Right in front of you. Thank you.
So good morning, everyone. Thank you for having us here
You're
today.
probably gonna have to lean closer into that mic because you have a soft voice.
That might be a little bit better.
Thank you.
Good morning. I'm Amy Dumont. I'm the Interim Director of Community Options for the Department of Social Services. So as you already have heard this morning, we're looking to add some temporary flexibilities that we were allowed during the public health emergency to be put into permanent authority into our home and community-based waivers. These flexibilities that we wish to keep will not just be through the ARPA spending period, but we're looking to make these changes permanently to our waivers. We are asking to make these changes based on feedback from our consumers, from our providers, and also from our contracted case management entities and our case managers through the Department of Social Services who are boots on the ground. We learned some lessons during the public health emergency, and we want to add some tools to our toolbox. So I'm going to go through each of the waivers, just high level about the changes that we want to ask your permission to add. And then I'm going to turn it to my colleague, Carrie Philick, who will talk to you specifically about some of the ARPA 9817 programs that we wish to add to our waivers as well. So first, I'm going to start with the home care program for elders, which is our largest waiver. And two of the proposed provisions that we would like to keep that we've had during the public health emergency were adding to the definition of mental health counseling. Mental health counseling is a service in the elder waiver currently. We would like that to be a service that is provided virtually. That worked well for our elder population who are not able to leave the home during the public health emergency. And that is something that we would like to keep that was effective for that population. The second is allowing adult day programs to provide virtual services via video communication, including virtual assessments and at least 2 meals per day when a client, specifically an elder for this waiver, is unable to attend the center in person. Their absence may be due to symptoms of a contagious illness or a recovery from such. It could be that they can't attend because they have an exacerbation of a chronic condition, or even inclement weather could be an issue. The adult day center also must document the wellness call with the client and then deliver the 2 meals per day. And that allowed many of our elders who use that service during the public health emergency to maintain that social connection and to also be able to be seen by a professional from the adult day center and also to receive the meals that they needed in their home. So we would like to keep that also as a flexibility in our home care program for elders waiver. The next I'm going to move to is the acquired brain injury waivers 1 and 2, and I'll call them out together because we would like to add the same services to both of those waivers. So the department would like to add licensed clinical social worker as a provider type under cognitive behavioral programs. Cognitive behavioral programs is a service currently under the waiver, and we would like to expand that provider pool. That has been an area of concern where we might not have a lot of providers in that delivering that service, and that would just help open up that door and allow our clients to be served well by adding that provider type. And then secondly, allowing virtual visits and reassessments when clinically appropriate with consent of the participant, again, in instances of contagious illness or recovery from an illness, exacerbation of a chronic condition, or an inclement weather. This will not take the place of a face-to-face visit, but this will allow us the opportunity to use the virtual assessment or reassessment in those instances if needed. And again, as I said, both the same 2 flexibilities for ABI 1 and 2. I'm next going to move to the autism waiver. In the autism waiver, we would like to add environmental adaptation. What environmental adaptations would mean is allowing physical adaptations to a person's primary residence. It would allow for them to have more access to assistive technology, widening doorways, modifying bathrooms, just to allow them to be able to stay safely in the community. And so we can ensure that their health and welfare is protected. So that would be a new service for the autism waiver. So those are the flexibilities in our 6 DSS waivers that we would like to keep. And now I am going to turn it over to Carrie to talk about the ARP 9817 programs.
Good morning, everyone. My name is Carrie Fillick. I'm a program manager with the Department of Social Services, and I'm happy to be here and to be able to talk about ARP 9817. Some of the initiatives we're adding, and just to give a friendly reminder, for ARP 9817, it's really to strengthen, enhance, and expand home and community-based services for people in Connecticut and the Medicaid program. I'm going to talk about some of the services that we are adding or we would like to add that we're implementing under ARP 9817. I'm going to give a brief overview of those services and then move through each of the waivers that we plan on and requesting permission to move forward with. I'm going to start with 2 of our evidence-based programs. The first one is called Training and Counseling for Unpaid Caregivers, what we call COPE, and that's of care of older persons, with dementia and their environments. Really what we look at with this evidence-based model is to support informal caregivers who are the backbone of the care in Connecticut for so many members and just an important part of service delivery. And what this model does, it's a predetermined set number of visits that helps a person remain independent in the community and to increase quality of life for them and their caregivers. And the focus is really to support informal caregivers and how could they help their loved ones or family members receiving services and increase quality of life in the community. Just to mention with COPE, we also have a model of this for people without dementia that's called Confident Caregiver, and it's embedded in the same structure where it's really to support caregivers, unpaid caregivers or informal caregivers in helping individuals. The second evidence-based model we'd like to add is called Capable Community Aging in Place, Advancing Better Living for Elders. And again, that's to increase quality of life. It's a highly individualized delivery model for people receiving services. We'd like to increase independence for our members, increase quality of life, like I mentioned, and allow people to be able to live safely in their homes or age in place. Really what those 2 services do, it offers people another choice of options to receive care in Connecticut. I'm going to move to 2 things we have up here. One is called remote supports, and that's connected to the expanded definition of assistive technology. And I'll jump into remote supports first. What remote supports is we're looking to implement a new program under ARP 9817, and that would allow people, again, have improved quality of life, increase independence, another service option for them to have in the community to access services. And what this does, it helps our members with supports by staff at a remote location. So really engaging with assistive technology to help people remain independent in their homes and to navigate and to manage and handle their health challenges or needs in their homes through assistive technology. Some of the services that we're hoping to deliver through this program would be on-demand virtual supports, unplanned visits. So if somebody would like to check in with their remote support provider, and then what we call an emergency backup PCA. So unplanned PCA visits and allowing this new provider type under this service to help with that area. What we hope to do with this program as well is to create a new provider type called Community Hub, and that places a lot of value on community. We'd love to have a provider in each of our towns, so 169, I don't know if we'll get there, but really connecting people to the community, knowing people want to be there and they find value in their homes and their locations. How can we coordinate with communities at a local level, create a community hub and really expand that and partner and help people integrate and remain integrated into their communities? The last thing I'll talk about is not necessarily a service that directly benefits the members, but it does ultimately impact a member's life in a positive way. And that's adding value-based payments, or what we call pay for performance measures. Really, it's to improve and incentivize whole person care by offering incentive payments to home and community-based service providers and home health agency providers as well. And really what it does, we're looking at outcome-based measures, person-centered goals, and evaluation of health disparities. Overall, value-based payments, it's a big model that we're hoping to implement starting with benchmark payments or benchmark requirements, where we do ask providers to complete certain measures or certain activities in order to receive a payment. And then in 2024, we plan to move towards outcome-based payments, outcome measures with clearly defined goals and objectives, which increase quality of life for our members, and really how can we coordinate a whole person care team. We do plan on utilizing Connie, which is Connecticut's Health Information Exchange, and we're currently building a home and community-based services platform to help support value-based payments and outcome-based measures. With that, those are the overall ARP initiatives that we plan to add. And I'm just going to quickly go through because some of these do repeat for the other waivers that Amy mentioned. So first and foremost, right here, the home care program for elders. We plan on adding those services here. Next slide, please. PCA, personal care assistance waiver. That's all right. I think I have it in my head as well. So you could see we're adding remote supports with that expanded assistive technology definition, training for unpaid caregivers, which is COPE and confident caregiver, capable and value-based payments. Next slide, please. Also adding it, ABI 1 and 2. Yep. Acquired brain injuries 1 and 2. We're also adding those. For Katie Beckett waiver, we're only adding 2 here. First, continuing the value-based payments and COPE, which I had mentioned earlier that we do have a version of this model for people without dementia, which is called Confident Caregiver. So we're hoping to also add that to Katie Beckett to support the caregivers who care for some of our most vulnerable children on the program. Next, for autism waivers, we're also adding remote supports, which includes that expanded assistive technology definition, COPE, capable, and value-based payments. And I believe that's it. And I'll turn it back over to Commissioner.
Thank you very much. So in summary, our expected outcomes is to have the ability to continue to deliver the critical care as we've identified in each of our waivers, and to continue to expand the services to the people that we support, that are supporting where they are. So you can see there's a specific emphasis on allowing as much flexibility as possible for people to remain in their communities and with their families. We want to also anticipate and continue to meet the needs of elders. Our state is rapidly aging. AARPs suggest that in the next 5 years, there will be more people living in the state that are over the age of 60 than not. We're also trying to expand access to provider networks, and we also are trying to provide through the value-based payments incentives to providers so that they can provide holistic and person-centered care. So we thank you very much for your time today and for the opportunity to present to you. And my fellow commissioners and I and our staff are here to answer any questions you may have. Thank you.
Thank you very much, Commissioner. So for all 3 of you, do any of these waivers dilute the services that are currently being given to consumers?
On behalf of DDS, no, is the answer to that question.
Same answer for Demas.
The same is true for DSS. No.
And do you have a waiting list prepared for us that shows us what each one of these waivers has for a waiting list?
Yes, we do. And I will make sure that you actually, I thought you had the list. I will make sure that you get the list.
We may have gotten it this morning, but
All right. I can read those
if
numbers.
you
If
could
that's,
read
I
those
would.
numbers for
Thank
us,
you
that
very
would be
much.
great.
Okay. So for our PCA waiver, we have 1,242. For our Katie Beckett waiver, we have 295. For our autism waiver, we have 2,008. For our acquired brain injury 2 waiver, our wait list is 101. And for our ABI 2, we have a wait list of 248.
And that's it for the wait list, Commissioner?
Those are the wait list numbers I have today, yes.
Yeah. And the acquired brain injury, now that you're trying to give the same services, does that dilute the services for anybody in the acquired brain injury one?
No, Senator, it does not.
Thank you. So we have some questions here, and I was looking for a power cord a little bit ago. My computer is going to die in a minute, so Right now I have Representative Walker. Do you have any questions?
No, ma'am, but I will follow the hands and let you know who's right behind you.
Senator Bethel, I got 3 given to me just now, so I am very happy to have all 3 of you, everybody helping me out. Thank you. Senator Bethel, do you have any questions?
Not at this time, Madam Chair. Thank you.
Representative Nuccio?
Yes, ma'am, I do, if that's okay.
Yep, go ahead.
Thank you all for coming in for the presentation. I'm sorry I wasn't able to make yesterday's meeting. I do have a few questions in regards to the slides that you have here. I noticed in quite a few places you said you are determining the plan's outcome-based measures. I was wondering if you could talk a little bit about what those outcome-based measures are and how they're being developed and kind of with what in mind. I'm a little concerned that what those value-based measures are.
Thank you, Representative. I'm actually going to add Carrie Felix to give you the specifics on that.
Yes. So we're still in development of outcome-based measures for value-based payments, hoping to start that in 2024. What we're looking at, though, are 5 specific measures: decrease avoidable hospitalizations, and we're partnering with UConn Center on Aging to help look at some of this information and the statistics around this. Increasing probability of returning to the community after an institutional stay. So we're looking at decreasing it to within 100 days. We're looking at increasing or helping a person meet their person-centered goals. So a big focus is really on person-centered care. What's important to a person? What are some of the goals and objectives they want to meet in the community, and how could those services support that individual? So we're looking at that, and the next one is to decrease health disparities in service delivery for the providers that are participating or will be participating in outcome-based measures, which is specifically home and community-based service providers and home health agencies. But we're still looking at all of that information, but those are the foundational quality measures that we're hoping to study and look at. And again, that's through the support of Connie and having this information available to the providers who are partnering with us in that.
Thank you. So I guess of those, some of them just, no offense by the term, seemed a little wishy-washy, right? Like the decrease in hospitalizations is something we can definitely track and monitor. My concern is that we may not have measurable goals that we can definitely show we are seeing a decrease or an increase in. So I would just ask that we look at that to make sure that the goals that we're achieving or that we're implying can actually be documented and achieved, because value-based payment can be good if used the correct way, but you have to ensure that you're getting the response that you need. And then the other question that I had is in regard to the value of the increase in rates. Do we know, Senator Austin, if these are in the budget, or are they being offset by the assumed decrease of people that are going to be coming off of Medicaid with the approval process? But I'm just concerned that we're increasing rates before we actually do the study that the governor wanted about rates.
So this is the Appendix K that is in the budget. This is revolving around Appendix K, which has been in the budget for about 4 years now, 3 years, when we first approved Appendix K, and this is seeking to make these permanent, which would transfer them from the ARPA part of the federal government, not our ARPA dollars, but the ARPA part of the federal dollars to permanent Medicaid dollars. And so it's not impacting the budget at all. This is moving, and I think people get confused by ARPA, but this is ARPA that is federal government ARPA, not state ARPA. And that way this makes sure that these dollars already appropriated in the budget are made permanent and that we will receive them permanently from the federal government.
Okay, so this is, the share between the federal and the state. So if I'm hearing you correctly, you're saying that we've already accounted for the current spend level in the budget, and this is not going to be an increase in any way to keep these rates, because I know we were receiving higher reimbursement from the federal government during the pandemic. that we're no longer receiving. So this should be budget neutral, is what you're saying?
So you're talking about when we were asking for increase in federal dollars, that was for the public health component of things. This is for Medicaid, and it is dollars that we've already incorporated into the budget. So it does not have an impact on the budget.
Okay, and then the last question that I had, I know that's 3, but the last question that I had was,
I'm keeping track.
I know you are. In relation to the clinical social workers and the cognitive behavioral therapy, are they certified to provide cognitive behavioral therapy? Is it within their scope of their role? Or are we taking them on because we have a shortage of psychologists in the clinic, the CBT arena?
Thank you for the question. That is part of the role as a clinician, as a licensed clinical social worker, is to help with formulate behavioral treatment plans. They will be added to the pool of current providers that we assert in the definition to CMS of our qualified providers that will be providing that service. So that it would be a role of a clinician of that caliber to be able to work with that population. I'm hoping that answers the question.
I think so. I just wanted to make sure that they definitely have the certifications. I know regular social workers, I don't believe they can do CBT. CBT is pretty complex, but I wasn't sure with clinical social workers if it was within the scope of their practice. So I just wanted to make sure that what we're asking them to do is definitely within the scope of their practice. Thank
That's
you.
why we specified LCSW in particular. So thank you.
Okay, thank you.
All set, Representative?
Yes, ma'am.
Thank you. Senator Lesser? Any questions? Representative Gilchrist, any questions?
Not at this point. Thank you, Senator.
Thank you, Madam Chair. I don't have any questions either.
Thank you, Senator. Senator Simonella?
Yes. Yes, I have a few questions, if you don't mind. I'm very happy to hear that the remote services are not going to be in lieu of face-to-face services and that you're going to still be providing services face-to-face. My question is, so by using remote services, are we wanting people to have computers in their homes? Is that how this is intended to be done? And if so, who would be providing those computers? And if so, who would be training? Because I would imagine we're dealing with a lot of elderly people who might not be as computer savvy as the rest of us. And I excuse myself too, because I'm not the most computer savvy person in the world either, but I just would like a little bit more clarity on that.
I will start, Senator, and then I'll turn it over to Carrie. It's not, what we're looking to do is to expand the definition of assistive technology so that it is not just a computer. And there's actually a wide array of technologies that elders can use in order to be connected with their family and with additional supports in their community. Computers are one of them. And with the providers that we currently have, some of them are already using, I'll actually turn to my colleague at DDS, are already using remote supports in communities. It does 2 things, one of which is that it does provide an additional degree of support, and connection, particularly if the person's family is not living in the state, which is actually quite common in some circumstances. And the second is that it also provides for a degree of privacy that many folks are asking us for. They don't necessarily always want someone in their home all the time, but they want to have an ability to be connected with someone. So this would actually allow us to broaden the definition of assistive technology. So we could look at everything that would be available. It wouldn't just have to be a computer. It could be a phone. It could be an Alexa. It's not the Alexa. I don't have one, so that's why I don't know what it is. So it could be a speaker. It's for me, it's a little creepy, but I know people love them. But it could be one of those speakers in your home where you could say, Alexa, please call my daughter-in-law. Alexa, please call my granddaughter. That's what we're looking at when we're talking about assistive technology, some of which may require training, some of which may not. There are also cell phones that are available that are specifically designed for older people to use. And we're looking for a more expansive definition under these waivers so that we can have access to all of that technology. Was there anything else you wanted to add?
Yes, excuse me, please. Thank you, Commissioner. What we also plan on doing is making sure that each person's evaluated or assessed who's looking to use remote supports, that they have an assistive technology assessment to do exactly what the commissioner just said, see what technology is available and which device or AT equipment might best meet the needs of that individual and serve that person in the community. So really looking at that whole person center, the whole person lens and what's available, what fits this person, and then to support through training. So it's a whole process that we plan on developing with this to make sure that the assistive technology really fits and is compatible with the person. And making sure, most importantly, that they know how to use this device or devices and how to navigate those, and their caregivers, if they're partnering from out of state, also know how to use the technology as well.
So my question is, once the assessment is made, who provides the assistive technology devices? Is that our program or is that at the cost to the consumer?
You're, there you go.
Thank you. Thank you. Jordan Chef, DDS. There are 7 Tech Act centers around the state that incorporate lending libraries, training, and the lending libraries allow you to loan out equipment so you can try before you buy. Within our waiver specifically, Medicaid dollars can be used to acquire certain equipment under certain definitions and with certain limitations. And we have found use of iPads, phones, there are two-way TVs, intercom systems, and the type of remote supports can be consistent, that you have an appointment on a standing basis where you get remote support for a specific activity. Some of those remote supports can be as needed or on call. And so the training can be provided within our waivers. We're looking to train within individual agencies that will be deploying the technology to make sure they have assistive technology trainers, people who will do the assessment and then do the training that follows. And I'm assuming the Tech Act centers would provide the same for the other waivers as well. And those dollars come in through Aging and Disability Services under Commissioner Porter to partially fund those Tech Act centers.
Okay, thank you. And I just have one other question, if I may.
One other.
Okay. So you talk about we're offering services for people with dementia, and then there's this other group, the confident caregivers, or so I'm assuming the confident caregivers are still professionals who are providing services, or is it for the family members of the people who fall under that category? And my other question is, who falls under that category? If you don't have dementia, then who is able to get these services?
Thank you for the question, Senator. The program is primarily for family members who are already providing care. So we know that there are a number of people in our community who already have what we describe as, and I'm probably borrowing a phrase from my previous life in serving people with intellectual disabilities, natural supports. But those supports require more training and more support for themselves as a person ages, as their physical, emotional, and mental health change. So part of what we're trying to do is to recognize that and then also provide a higher level of training and support for those families and their communities. And it is usually family, but sometimes neighborhoods and communities come together and support people. And we want them to, in fact, feel confident in what it is that they're doing, because medications can get more complicated. Transferring people from their beds, onto other pieces of furniture or even to bathrooms can get more complicated over time. They can be injured and other people can be injured. And I know this, from the work that I did before and now. So what we're really trying to do is to recognize that is definitely a reality, especially with people with dementia, and that to provide them with the support that they need in order to do that. And again, this comes from our experience and what we've heard in our community as to what it is that people need. So, and I'll turn it over to Carrie to provide more details.
Thank you, Commissioner. So under COPE, care of persons with dementia in their environments, that's the program title. Confident caregiver, that's a similar program title. It's just minus that dementia diagnosis. There are we do plan on partnering with occupational therapists and certified registered nurses to actually deliver the services under those two models. And it's a very prescribed prescribed program under both COPE and competent caregiver with a predetermined number of visits to help the informal or unpaid caregivers and the member, whether it's supporting with training or as a person's care changes or needs change, to help the informal caregivers understand and move with that. So really the specific direct care would be provided through a registered nurse and occupational therapist. Confident caregiver is just an alternative model for people without a dementia diagnosis.
And who fits in that category? Is that just people with disabilities of any age? I'm just trying to find who's in that catchment of non-dementia patients.
Yeah, so there could be older adults. So we plan on adding this to the home care program for elders. So older adults without a dementia who might be eligible for a competent caregiver, adding it to the Katie Beckett waiver, which serves minor children, the PCA waiver, autism waiver, ABI 1 and 2. So it's more based on functional needs and not necessarily specific, but to be able to offer people another option.
Terrific. Thank you very much. And thank you for indulging me.
Representative Case?
And just a few questions
I don't know what you mean by a few, but
yesterday. So when we talk about appendix, well, could be here a while. So when we talk about Appendix K and we talk about ARPA dollars, we're codifying Appendix K. Is this all within budget, so we're not going to have a loss of services, or is there an exit plan if there's no dollars that come with this through you?
Thank you for the question. No, it is already included in the budget. So this is making permanent services that were in Appendix K that have already been accounted for in the general fund. So we will not be back. That has already been accounted for in the budget.
Okay, and I thank you for that clarification, because some questions came yesterday through me as far as we keep mentioning ARPA, but these are codified within our current budget.
Yes.
So we don't have to worry about making an exit plan on losing these dollars.
Right. So just to repeat what Senator Austin had summarized earlier, and thank you, Senator. I was prepared to answer the question, but we appreciate it. When we speak about ARPA, we have our state dollars and our federal dollars, as she said earlier. And so what we're really looking to do is to make permanent what has already been allocated. And the state has already made provisions for that. So that's why those dollars are permanent. And we don't have to be concerned about that.
I thank you for that. And one last comment, and I hope that we can alleviate even more waiting lists, because I know Katie Beckett was come down, but also with the legislation that we put through, the 2008 on the autism waiver, hopefully we're working with funding in that bill that is going to start to deplete that and help out decommission DDS and yourself as far as funding for those particular waiting lists. But I thank you for bringing this forward, and thank you for the clarification so that everything is codified within the budget. Thank you, Madam Chair.
Thank you. Representative Hughes?
Thank you, Madam Chair, and thank you, commissioners. I'm asking about 3 points that I didn't hear in there, and anybody can answer. One is, does the waiver cover, especially for the COPE program, the caregiver support groups that I know are offered often either through the day programs or the municipal agent, maybe at a senior center? Two, I'm wondering, is transportation covered or not covered to get to some of these programs? I know in human services, we've been looking to increase reimbursement for transportation. And third, have the Connie health system security issues been addressed about concerns about information sharing and protection of health information from cyber attacks or breaches of security? Thank you.
Thank you, Representative. I will answer the last question, and I will turn it to Carrie to answer the first two, and I'll address the Connie question.
Thank you. For COPE, it's an evidence-based model. It's administered through Drexel University and Thomas Jefferson Hospital. We're hoping to embed the model so it's a predetermined structured number of visits relates to assessment, a care plan, development of those services and training and technical systems to carry out that plan and monitoring. So it wouldn't, COPE wouldn't work outside of what the model is structured to be. So supporting through other support groups, that's not part of the current model. And Amy, if I could pass it to you for transportation to and from other services, but that wouldn't be offered under COPE. COPE, it would be delivery of services in the person's home.
In terms of transportation, in some of our waiver programs, we do have transportation as a service, especially in the ABI and in the autism waiver. Where if a client needed support in getting to something other than a medical appointment, we can certainly assist with that. And then we also have the non-emergency medical transportation program through DSS, and that could be another option for people in terms of getting to places that they need to get to that are important for them. I'm hoping that helps to answer that question.
Yeah, I guess I'm just clarifying that in terms of this waiver that we are approving today, that's not in it, right?
No, transportation is not
No.
specifically in it.
All set, Representative?
Was Commissioner gonna address the Connie issues?
Yes, yes, I was. And I will do this in the very limited context of being a board member on Connie. So the security of Connie, as you know, is a continuous concern, as is the security of any other personal data that is kept on state or quasi-governmental or any level. I can tell you that as a board member for Connie, this is it is an issue that has been worked on, and I am, how can I put this? I know that it is the highest priority and that every measure possible is being taken to be able to secure the information that is deposited in Connie. And that at every board meeting, this is a concern that is being raised and discussed. And Mark Raymond, who is our state's chief information officer, is also on the board, and he provides a lot of support, not just through his advice, but actually through specific supports and technology that is provided so that we can make sure that that information is secure. So I think those of us that sit on the board, and I think the leadership at Connie would tell you that we continue to collect information. We're highly cognizant of the concerns and do everything possible to make sure that that information is secure as possible.
Thank you.
All set, Representative? Representative Dathan?
Sorry, I had some issues unmuting. Thank you so much, DSS, for your presentation this morning. Very helpful. I would like to get an understanding how the waiting list for each of these programs have moved over the last several months, and also any sort of updates and assumptions with passing of these waivers, how that'll affect the waiting list going forward. As you know, we in 5001 this year, that was one of our key initiatives. If you can share that information with the administrator, I'd greatly appreciate it. I don't expect to have it straight, but I heard the numbers that you shared with Senator Austin at the first part of the Q&A session. The second question that I have is, in terms of the value-based payments, I know there were some questions regarding that. In terms of how is the agency going to monitor the sort of metrics that are used, and how have we determined which metrics are going to be used?
Thank you for your question. As Carrie had testified earlier, we are still in the process of developing those metrics. The ability to be able to do that will help us to determine which ones will be the most effective. But in talking to our community partners, let's just put it that way, providers, these are the ones that we've landed on, not just exclusively with respect to DSS, but really talking to people who are receiving the services and people who are delivering the services. Their call is for a more holistic approach to delivering care. And these are the things that they're looking for when they look for a holistic approach to delivering care. That's why we chose these specific ones as opposed to others. We will continue to develop those in conjunction with the partners that recommended them to us and with our own experiences within the agency and in partnership with other state agencies and other community partners and other stakeholders. So we will not do that in a vacuum. The issue that was raised earlier about them being measurable is one of the things that we're also trying to determine now. So we are actually just in the spirit of full transparency in very early stages of this, but having considered a wide array of things that could be measured, these were considered to be the ones that had the greatest impact on the quality of care that people receive. So what we can do, of course, is we can come back to this committee with some of our recommendations as we continue to refine those ideas and bring them back to you.
Oh, sorry. Thank you.
I'm
That's
so sorry. We can do that.
Yeah, that's great news. I was going to ask if that was going to be part of MAPOC or as part of the appropriations and human services discussions, because I know we'd really like to keep an eye on those, monitor those, because there are a number of advocates that support value-based payments, and there are a number of advocates that don't for various reasons. And my main concern is that everything that we do is measurable and we have the positive outcomes that we're hoping for to serve our safety net in our state. So thank you so much for your presentation, and thank you to your agency for all the work that you do in supporting our safety net. Thank you, Madam Chair.
Thank you. Representative Porter.
Thank you, Madam Chair, and thank you all for your presentation today. I wanted to go back to the HCBS waiver for elders. You were saying that you were looking to make the waiver changes permanent, which we understand. I think it's a great idea. And you also spoke about boots on the ground and lessons learned. Could you just expound on what lessons were learned, please? Through you, Madam Chair.
So the lessons that were learned were basically that our clients need more access, especially in the elder waiver, to those mental health counseling services. And that was one of the reasons why the department, our provider community, our consumer population, and our case management staff felt that that was a measure that we should keep. A lot of elders struggled at home, a lot of social isolation during that time, and that mental health counseling was really an important piece for them. And to allow that to be continued is very beneficial to that population. So that was one lesson we learned and why we want to keep that measure. But also the adult day programs. The adult day programs are a wonderful support for our elders. They bring them a lot of support, and during the pandemic, it allowed them to stay connected. And now, hopefully, that with the pandemic behind us, people could become ill. They also could get sick. I mean, there's other illnesses, there's other comorbidities that could exacerbate. And we want them to be able to continue to be connected to a community like that. So that's where the decision from the department and again, our providers and our consumers felt that that was a great support to have, and to be able to get their meals and get their nutrition at home and to be able to be seen by somebody from the adult day center. That was a perfect opportunity. So that was the reason why we chose we want to keep those two measures. And the folks with the boots on the ground, the case management team, either our contracted entities or our state case managers, also felt that that was a service, those two services provided so much benefit for that population. So that was the decision point.
Thank you for that. I really wanted to get that on the record because I've heard that from people in the community as well that are using some of these waivers and vouchers. Transportation is a huge issue down in my district, especially when we're talking about elder care, senior citizens being able to get around, and, you know, just telehealth. alone made such a tremendous impact on closing the gap on health disparities in poor communities where people don't have the same kind of access and affordability. So I just wanted on the record, I totally agree with what you're doing.
If I can
Um,
just expound one second.
Yes,
Adult day centers provide such a great support, and when you're talking about transportation and you think of inclement weather, and what a great opportunity that is for our elders to stay connected in times like that. So, thank you.
absolutely. And to be able to stay in place and stay safe, that is also another great benefit. The last question that I wanted to ask you went through, decrease in avoidable hospitalization, increase in probability of returning to community. You talked about helping people meet person-centered goals. And then you mentioned decreasing health disparities. And I would just like to know just a little bit more about the decreasing health disparities part through you, Madam Chair.
Thank you for the question. So we're still in development of a lot of those measures for outcome-based measures under value-based payments. I didn't mention earlier, but have the opportunity now. We are partnering with Yukon Center on Aging, helping us evaluate some of these measures. We're also working with the National Committee for Quality Assurance and NCQA to help determine and put some guidelines and structure around person-centered goals. So really from a person's perspective, what do they want to achieve and how do the services help them achieve that, and putting some really good standards. And lastly, related to health disparities, we're currently working and have a meeting later today with Yale Core, and I forgot what the Center on Research and Evaluation, and we're partnering with Yale Core to help look at health disparities and how we could address those with home and community-based service providers and home health agencies through a measure with outcome-based payments. But once we have more detailed information, we're happy to share that.
Thank you. I would really appreciate that. I'm a big advocate of person-centered. People closest to the problems are closest to the solutions, right? So empowering people to have access and to make decisions that they know they can benefit from is extremely cost-effective, if you ask me. So thank you all again for being here today, and thank you, Madam Chair.
Representative McCarty.
Thank you very much, Madam Chair. And again, thank you to all the commissioners for their presentations today. If I may just go back for one moment to the mental health counseling, because I do agree this is a very important area that we need to keep an eye. But I noticed there's a prohibition on the telephonic services. And could you just expand for a moment? I know I brought this up at another occasion, and I think this has to do with one of the federal requirements. But as we're talking about some of our elderly that really may not have access or the knowledge, even with the assistance, I've heard from many psychologists that the telephonic services were really very valuable. So just if you could just explain to me, why is that a federal prohibition?
I will start and then I will turn over to my colleagues so they may want to expand. When the public health emergency ended, there were specific expansions that we were of delivery of services that we were allowed to provide under the public health emergency. But with the wind down and actually the unwinding, as we call it, there were some of those that we did have to pull back, and we did issue a bulletin that explained what all of those were and what some of those rules were. So you're absolutely right. It was really specifically driven in part by some of the things that we could not do anymore because of the unwinding of the public health emergency. The other specific thing is that when it comes to the delivery of mental health services, you can access those services by calling and getting the help, but clinically, and this is based on feedback that we've received, not just from our own internal clinicians, but from clinicians and other stakeholders, that is better delivered when you can at least see the person, even if they can't get to you personally. So part of it is that it is a better clinical approach to have the person at least be seen face-to-face to the extent that that's possible than telephonically. That is one of the reasons that we put that particular those are actually a couple of the reasons that we put those particular restrictions in place. And CMS has approved those, and that is the direction that we have been going in. When we issued our public bulletin, excuse me, when we issued our policy bulletin with respect to some of the things that we would be able to do for telehealth, it was the first bulletin we issued, we got a lot of feedback on, we made a lot of changes to that. And then we issued a subsequent bulletin that still had that telephonic restriction only under very limited circumstances, but that wasn't necessarily applicable to all circumstances. But right now, that is the way in which I would say clinically it's most appropriate to deliver mental health services. So that's why that we have the prohibition here.
Certainly, Commissioner, I wouldn't disagree with that assessment, but I also think there may be some individuals that would really benefit. So I would just like to just go on the record to say, I think that we should continuously look at that to see if we're leaving anyone out, because while you're mentioning the best clinical approach, but I just wanted to make that point. And then if I may just go back to the COPE model for a moment, at some other point, maybe just have a little more information about what type of training. I know you talked about the assistive technology piece, but what type of training and counseling maybe those caregivers, family caregivers may receive. And appreciate the presentations today on all of the waivers, and particularly happy to see that we are trying to look at what's in the best interest and benefit person-centered, like Representative Porter said, bring that quality of life to these individuals. But just a little bit about the training, if I could, for the unpaid caregivers.
Thank you for the question. So really it's, I would say it's member specific. So what's documented in a person's plan of care? What are their needs? How can a person, how can an informal caregiver support that through the COPE model? Some of the examples that we've been using, and I have more information that I could provide on this model. But an example is as needs change, if there's medical components of care for a person, and the unpaid or family caregiver might need extra support or training on how to administer some of those methods. Commissioner, you had mentioned transferring, so supporting a person when they transfer from, say, a bed to a chair, and assisting that person and making sure that caregiver knows how to properly assist the person. So really it's dependent on the person, but I'm happy to share more information on what the COPE model is and any information we have on that.
Thank you very much.
All set, Representative? Okay, Representative Kennedy.
Thank you, Madam Chair, and thank you all for being here today. I jotted down some of the numbers, but I think you said you would get us the numbers on the wait list. Thank you very much. And also regarding the wait list, I think someone started to ask it, but I'm not sure if they finished the question or we got the answer. How long is someone generally spend on a wait list, like for the autism waivers? What's about the time frame to be on a list?
Well, thank you for the question, Representative. It is a long time. A person can wait up to 24 months or longer on the wait list for autism. But there are a number of factors that affect that, it doesn't make it a better experience for those that are waiting. And the primary factor is that there's very specific training that is required to support someone with autism. And, depending on the degree of autism they have, there are different levels of specialty that you need in providers. They are very difficult to find. They are very expensive, and rightfully so. They are highly trained and well paid. And they don't necessarily stay with providers very long. They do move to find better opportunities, more pay, all of the reasons why everyone makes different career moves. We very much value those providers, and we recognize that they are often overwhelmed, so the demand is great. That is primarily what drives the wait list, to be quite honest with you.
I appreciate your response, Commissioner. Thank you so much. And just kind of following on the line of speaking with Representative Porter, is we did learn a lot during the pandemic, and especially with our seniors and our most vulnerable being alone in a lot of respects. So I'm very appreciative for all the work that you've done and your continued work. Thank you, Madam Chair.
Thank you. Representative Johnson.
Thank you, Madam Chair, and thank you, Commissioner, for your presentation and everybody else, staff members, for your presentations today. Very much appreciated. I do have a question though, and as many know, I have 3 homeless shelters in my district. And one of the things that our social services director has been indicating to me is that senior citizens are having a hard time locating home care and services in a home after they are put into the hospital setting, and then there's really no place to discharge them to with home care services. And so we're running into a real problem here, making sure that our seniors actually have a place to go. And I wondered, in terms of this waiver and home care services, are we addressing some of the seniors who do not have a place to go, or people who also have been deemed disabled by Social Security because of an injury that they suffered and then went into a hospital, then to a nursing home, but then didn't have a place to go after that? So I'm just wondering where we are in that process. I know that we're doing more this last legislative session with making sure we have better hospital discharge planning, which may fit into some of the work that you're doing, but I just wondered how we are addressing maybe some of these maybe newer issues that we've been faced with, at least in my district. Thank you so much for your work.
Thank you for your question, Representative. Housing specifically is not included in any of the waivers that are in front of you today. That doesn't mean, however, that we are not acutely aware of how chronic the housing issue is, specifically for seniors, and affordable housing as a chronic issue throughout the state for all of our families, and we know this. It is, as you may know, it has been one of the governor's priorities. He's worked very hard with our housing commissioner to make sure that there are more resources and access, money, to be able to build more affordable housing, including housing for seniors. These specific waivers do not necessarily address that, but they do attempt in some way to address the other issue that you raised, which is really having, once you do have housing or you have a place to be discharged to, that you can have the supports that you need when you get there, and that those supports can take many forms that aren't necessarily restricted to the supports that we had under the Appendix K waiver during the public health emergency. So we have many issues in our state and across our country when it comes to affordable housing, to waivers, to providing supports for the elderly and those with disabilities and those with behavioral health concerns and those with substance dependency. And we know this, and we will be addressing this not only in Connecticut, but across the country. But with respect to these particular waivers, we are hoping that in some measure, particularly when it comes to the home and community-based waivers, that we can try to begin to address some of the concerns as we continue to work diligently toward resolving, or at least beginning to address the issues that you raised today.
I just want to thank the commissioner so much for her understanding of the issues that we're faced with. Thank you, Madam Chair.
Thank you. I see no other hands up, either in person or online. So we're going to close or adjourn the public hearing. No. Oh, I do have public people here. Oh, my goodness. I didn't think anybody would bother to show up. We have Andre Brell. Ah, come on up. There you go. No. Go ahead, sir. Just make sure you're, there you go.
All right, I got it. Good morning, dear members of Appropriation and Human Services Committee. My name is Andre Brell. I'm a president of Juniper Home Care. It's a multi-service agency that offer homemaker companion, PCA services, Meals on Wheels, adult family living, but we also have 4 adult day services. And West Hartford, New Britain, and Hamden, Connecticut. And today I represent here Connecticut Association of Adult Day Services, which includes 28 members. I would like to express my sincere gratitude to the members of Appropriation and Human Services Committee, including Senator Austin, Representative Walker, Senator Bersel, Representative Nuccio, Senator Lesser, Representative Gilchrist, Senator Seminara, and Representative Case. Your dedication and support are greatly appreciated. I would like also to extend my thanks to the state and the Department of Social Services for recognizing the significance of remote services for adult day services. The inclusion of remote services in the waiver amendments has been instrumental in ensuring continued access to vital care during the COVID-19 pandemic. Remote services in adult day programs have been proven to be immensely beneficial, allowing individuals to receive necessary support and care from the comfort of their homes. Beyond the pandemic, it is crucial to make remote services a permanent part of the healthcare system. They provide a lifeline for those who are temporarily unable to attend in person due to post-acute rehabilitation, physical or mental illness, or just in need of doctor-recommended break. Also, I want to emphasize invaluability and collaboration between our association and the Department of Social Services during the early stages of pandemic. In March of 2020, as COVID-19 just began to spread, our industry faced uncertainty. However, thank you to swift action in cooperation of our association and Department of Social Services, temporary policies and procedures were implemented within the days. This measure ensured uninterrupted, comprehensive services for our clients, while also keeping our customers and staff safe. Importantly, these actions did not require any additional state funding. As remote services in adult day programs have been significantly reduced since then, most of our clients continue to attend adult day centers in person. Nonetheless, remote services remain a vital and necessary resource for those who require temporary support. It is my sincere hope that we can continue to build upon the success of remote services and further expand them to adult day service in the future. Looking ahead, we eagerly anticipate the results of the evaluation that the Department of Social Services will conduct as a result of recently passed legislation. The evaluation will explore avenues to expand adult day services to more individuals. We hope that as a part of this analysis, the Department of Social Services will consider the future expansion of the PCA waiver and the addition of adult day services of CFC, Community First Choice waiver. This measure would greatly enhance the availability of adult day services and ensure that more individuals can benefit from support that they provide. Thank you very much for your time and consideration.
Well, and thank you very much for coming up. Appreciate it. Are there any questions? Representative Walker?
Thank you. And thank you, Mr. Braille, for coming up to testify. I guess you can answer the question that I think a lot of us ask. How well do older individuals take to utilizing computers or doing Zooms or doing technology interventions by healthcare workers? How well has this worked for your group?
Thank you for your question. Yes, I try to answer this. When, again, like I mentioned, when COVID just started spreading and we were able to move to wellness call, remote services, we call them, it was a lot of challenge at the beginning because Zoom, if you remember at that moment, was a challenge not just for elderly people, it was a challenge for everyone else. We didn't even have Zoom as a household name at that point. However, as you know, we quickly adapted. We made a home visit if necessary. In many cases, we did to make sure that our customers, our clients, are able to use computers. But it was other technology like just a phone, just a speaker phone. It was in many cases was enough to speak, to discuss, to go through the day. And our clients they use this service very broadly. In some cases, it was just conversation on, like well-being call. In some cases, the call was for 15, 20, or even more minutes because they want to talk about what's going on in their lives. Also delivery of meals, delivery of 2 meals was important as well, because our staff was able to come to clients' home and see them face to face, make sure that they are well taken care of, and they have no needs, no emergency needs at that moment. We also had some nursing visits as well, if clients needed, especially when the transition just started, if client needed medication management, our nurses were able to provide medication management as well. But overall, technology was a challenge, but within time, we have adopted, and everyone was taken care of. We have group meetings, we have Zooms. My adult days, if I'm talking about me, my adult days, and some of them are cultural. Like I have one of the center is mostly Ukrainian and Polish speaking. They love their favorite activities. Learning English as a second language. They love it. They do it every day. I was able to continue to do these classes on Zoom for them, and they love this, obviously. I hope I answer your question.
Thank you for that. So let me just ask in general, what percentage of your I hate the word elderly because it sounds like they're out of touch. Older population, what percentage of the older population that you serve would you say have access to these types of meetings, have computers or at home now on their own?
I would say most. I would say I cannot tell you exactly, but most of our clients have ability to use not necessarily computer. Computer maybe is a stretch. Not everyone have laptop or desktop, but smartphone is definitely. And smartphone is excellent tool. And like Commissioner mentioned before, the smartphones that even issued by the state, many of them have those services that are covered by the state. They are smartphones. They are not just dial. In the case of emergencies, they are very internet or cell connected. They have service, and you can see face to face, or you can definitely text or obviously use traditional phone call.
So more than half of your population has access to this video connection, correct?
In my case, my centers are urban. They are in the housing. Many of my clients live in the higher population. I would say most.
That's all.
Almost everyone.
Okay, thank you. Thank you for your answer. Thank you, Madam Chair.
All righty. Thank you, sir. I see no other questions. Up next is Chrissy Shantini, who is online. Ma'am, you have 3 minutes.
Yes. Hi, good morning. Good morning, Senator Austin, members of the Appropriations and Human Services Committees. Thank you so much for having me today. And thank you so much for your consideration. My name is Chrissy Scatini. I'm the president of the Association of Adult Day Services. I'm just here today to speak briefly in support of these waiver changes, particularly the Adult Day Centers remote service becoming a permanent option. As it's been mentioned, we found these services to be extremely valuable over the time of the public health emergency and beneficial to our consumers and programs. As Ms. Amy Dumont had described the service, it allows us to provide a remote service in the event a client is unable to attend the center, including a wellness check and delivery of 2 meals to their home. Previously, if a member was unable to attend, it would often leave the access agency and case manager scrambling to find temporary services just to make sure the client's checked on, to make sure they have meals and so forth. And with ongoing workforce shortages, finding these replacement services became more and more of a challenge. It would oftentimes mean leaving the client at home with no service, or it would be a service that would incur additional cost to the state. It would be a more expensive service than the adult day. But by allowing our programs to provide these remote services, we're able to stay in contact with the client. Our staff is already familiar with them. We can assess if they may need additional support, whether it's a doctor visit with a doctor, or if we need to contact their family members. We're very close, working closely with these clients, so it's easy for us to help and jump in the time that they're not able to attend. We also can do this with no additional cost to the state, because anytime a client's already authorized for our service, that cost has been included in their budget. And by providing the remote service when they don't come in, there's no additional charge or no additional cost from what was already planned and budgeted. And we also have found that in regards to the technology, just to address that as well, that the clients have really come to be fond of this option as far as Zoom, and knowing that they're going to be checked on either by phone or video. It has really grown over the last few years. And of course, I just also want to echo what my colleague, Mr. Andre Brell, had just mentioned, that we really value the collaboration we've had with DSS over the last few years, particularly Miss Amy Dumont, her team at the Community Options, and everybody who's been working with us to expand adult day services. Together, we've been able to meet the needs of our consumers and work towards new initiatives in the future. We do look forward to expanding our programs, access for consumers throughout the state, be it through the PCA waiver or maybe through the Community First Choice waiver in the future. And we're very grateful for that collaboration. And lastly, I just wanted to mention on behalf of our association that we're truly grateful for the support that we've received from these committees through the time of legislation and support for our programs over the last few years. It has been wonderful. It's truly appreciated. And we look forward to your continued support as we move into the future. So thank you so much. And I'd be glad to answer any other questions.
Thank you very much, Chrissy. I don't see any questions for you. So I believe now we can adjourn this joint hearing, and I will turn the floor over to Senator Lesser. Are you all set, Madam Administrator?
Actually,
Is that a yes? Okay, Senator Lesser? Or
it's
Representative?
actually going to be myself, Senator.
Okay,
Great.
go ahead.
I'd like to convene the meeting of the Human Services Committee. And then we're going to do a roll call vote on the following amendments. 1915C Medicaid waivers 4, comprehensive supports Medicaid waiver, the individual and family support Medicaid waiver, the employment and day supports Medicaid waiver, the home and community-based services waiver for elders, the personal care assistance waiver, the acquired brain injury waiver, the acquired brain injury waiver 2, the home and community support waiver for persons with autism, the mental health waiver, and the Katie Beckett waiver. Can I have a motion?
So moved.
Is there a second by Senator Lesser? Any comments? Seeing none, would the clerk please take the tally, or please take the roll? My apologies.
Good morning, Representative Gilchrist,
Yes.
Senator Lesser,
Yes.
Senator Seminara,
Yes.
Representative Case,
Yes.
Senator Gaston, Representative Dathan,
Representative Dathan votes yes.
Senator Marr, we'll come back, Representative Butler,
Representative Butler votes yes.
thank you, Representative Cook,
Representative Cook votes yes.
can you repeat that one more time?
Representative Cook votes yes.
Thank you, Representative Comey, Representative Exum,
Representative Exum votes yes.
Representative Fortier,
Representative Fortier votes yes.
Representative Hughes,
Representative Hughes votes yes.
one more time for me so I can see you on camera.
Representative Hughes votes yes.
Thank you. Representative Johnson,
Representative Johnson votes yes.
Representative Kitt,
Representative Kitt votes yes.
Representative Leeper,
Representative Leeper votes yes.
Representative Santiago,
Santiago votes yes.
Representative Buckby. Representative Ferraro.
Representative Ferraro votes yes.
Representative Mastro Francesco. Representative Pizzuto.
Representative Pizzuto votes yes.
Representative Paletta. Senator Gaston. Senator Mar.
Senator Mar votes yes.
Thank you. Representative Comey. Representative Buckby. Representative Mastro Francesco. Any members of the Human Services Committee that haven't casted their vote? Okay, thank you. Please give me a moment.
Madam Clerk, would you please announce the tally?
Yes, the tally is 17 voting, those voting yea 17, those voting nay 0, those 0 abstaining, and absent not voting 5. Thank you, Madam Chair.
Thank you, Madam Clerk. The Human Services Committee is now in recess.
Thank you, Representative Gilchrist. The Appropriations Committee will convene, and we will be voting by roll on the amendments to the following 1915C Medicaid waivers for comprehensive supports, Medicaid waiver, individual and family supports, Medicaid waiver, employment and day supports, Medicaid waiver, home and community-based services waiver for elders, personal care assistance waiver, acquired brain injury waiver, acquired brain injury waiver 2, home and community supports waiver for persons with autism, mental health waiver, Katie Beckett waiver. I'll entertain a motion for this.
So moved, Madam Chair. Second.
Moved by Representative Porter, seconded by Senator Berthel. Is there any discussion? Seeing no discussion, Madam Administrator, if you could call the roll.
Senator Austin,
Senator Austin votes in the affirmative.
Representative Walker,
Representative Walker votes yes.
Senator Hartley, Representative Exum,
Representative Exum votes yes.
Representative Paris,
Representative Paris votes yes.
Senator Berthel.
Good morning, Madam Administrator. Senator Berthel votes in the affirmative.
Good morning, sir. Representative Nuccio,
Representative Nuccio votes yes, ma'am.
Senator Anwar,
Senator Anwar votes yes.
Representative Baker,
Representative Baker votes yes.
Representative Belinsky,
Representative Belinsky votes an enthusiastic yes.
Representative Callahan,
Representative Callahan votes yes.
Representative Candelaria,
Representative Candelaria votes yes.
Representative Chaleski,
Representative Chaleski votes yes.
Representative Curry,
Representative Curry votes yes.
Representative Dathan,
Representative Dathan votes yes.
Representative DiCaprio,
Representative DiCaprio votes yes.
Representative Delaney,
Representative Delaney votes yes.
Representative Delnicki,
Yes.
Representative Dillon, Representative Felipe,
Representative Felipe votes yes.
Senator Flexer,
Senator Flexer votes yes.
Representative Fonsello.
Representative Fonsello votes yes.
Nice to see you, Marty.
Thanks. Nice to see you.
Representative Garabay,
Representative Garabay votes yes.
Representative Gibson,
Happy Friday, Madam Administrator. Representative Gibson votes yes.
thank you, sir. Same for you. Representative Gilchrist,
Representative Gilchrist votes yes.
Senator Gordon,
Good morning. Senator Gordon votes yes.
thank you, sir. Representative Gonzalez. Representative Haddad. Representative Hall. Representative Harrison.
Morning, Representative Harrison votes yes.
Thank you. Representative Hoxa.
Good morning. Representative Hoxa votes yes.
Thank you. Representative Johnson.
Representative Johnson votes yes.
Representative Khanna. Representative Kennedy.
Kennedy votes yes.
Senator Kushner.
Good morning, Madam Administrator. Senator Kushner votes yes.
Thank you. Senator Lesser.
Senator Lesser votes yes.
One more time.
Senator Lesser votes yes.
Thank you. Senator Marks.
Senator Marks votes yes.
Representative McCarty.
Representative McCarty votes yes.
Senator McCrory.
Well, Senator McCory votes yes, Susan. Nice to see you.
Nice to see you, sir.
All right.
Representative Nolan.
Representative Nolan, happy to vote yes.
Thank you, sir. Representative Porter.
Representative Porter votes in the affirmative.
Representative Osborne.
Representative Osborne votes yes.
Representative Reyes. Representative Rosario.
Representative Rosario in the affirmative.
Representative Rutigliano. Representative Ryan.
Representative Ryan votes yes.
Representative Sanchez. Senator Slapp.
Senator Slapp votes yes.
Representative Sims.
Representative Sims in the affirmative.
Senator Summers.
Senator Summers votes yes.
Representative Tersiak. Senator Winfield. Representative Zawistowski. Are there any members of the Appropriations Committee?
Madam Administrator?
Good morning, Senator Hartley.
Yes, good morning to you, Madam Administrator. In the affirmative, Senator Hartley in the affirmative.
Thank you, ma'am. Are there any other members of the Appropriations Committee who have not? Hi. Good morning.
Say good morning. Good morning.
Good morning to you too.
We're trying to behave. A little stretch.
Well, I don't know if she's going to follow her grandmother's lead. I'm not certain behaving is in the DNA. Is there anyone else?
It's straight and narrow here. Thank you all.
Thank you. Any other members of the Appropriations Committee who would like to now cast their vote?
Madam Administrator, Senator Winfield is having a hard time trying to get in. Can we give him a minute just to see? He's been trying.
Why don't we do this, Madam Chair? I will resend the link to him.
Okay.
Just stand in recess for a moment, please.
Thank you. Thank you. She
Yeah.
sent it.
Recess for a minute. No pressure. Well, look at. Hi, Jamie. I see you have a little one there too.
Yes.
Representative 40 years granddaughter wanted to say hi too. You want to say
Oh,
hi,
very
Lou? Say hi with your voice.
Now we're seeing all the little ones. There's Rose. Hi, Rose.
Where's Rose? Oh, Rose.
Hi, Rose.
Hi.
You running the computer over there at that house of yours?
Can you wave? Can you lift up your hand and wave?
What? Say hi to Rose. Rose's birthday's the same as yours.
See, Senator Flexer's daughter's on too, so now we have 3 kids.
3 babies.
Say hi.
Babies, all girls, all
Yes.
girls.
Bell
Running the
rule
world.
the world.
My friend Joe. I'm gonna turn the sound
Representative
off.
Walker, the link has been resent to Senator Winfield, so if you could let him know that. he should
Yeah,
get-
I'm talking to him now. He said he's trying it again.
I also sent him my link, so if we see a second Taylor Hyde, it could be Senator Winfield.
Okay, Taylor said she sent one to you too, so try her also.
Yeah, I'm trying.
Yeah, she says she's got melons in her backyard.
Who has melons?
Tony,
Yeah. Oh, I have melons in my backyard. Yeah.
you. We were talking about you, talking about your plants.
Yes. Oh, yeah. I've got
The green thumb.
no. They just like the rain.
All right, come on, Gary.
What do you need, a large or a medium?
He said it looks like it's coming. He's logging in. Thank you.
Sorry about that.
That's
I don't know
okay.
why it was taking so long. Come on, go through. It's showing logging in. What's going on?
No, that's Corey. That's okay.
It's
It should see me.
okay. Okay, I'll look for you. Okay, thanks.
There
Bye.
he is.
Yep. Okay.
Senator Winfield, good morning, sir. Oh, we can't hear you.
Well, we've got it. He's Taylor.
There you
at the mo-
go.
He's Taylor at the moment. Okay, good. Okay. Good morning, sir.
Good morning.
Would you like to vote?
Yes, I would. In the affirmative.
Thank you, sir.
Thank you.
Madam Administrator, if you could announce the tally.
Total number voting 43, those voting yea 43, those voting nay 0, those abstaining 0, those absent not voting 8.
Thank you very much, Madam Administrator. The waivers all pass. And I'll take a motion to, from the Appropriations Committee to adjourn.
So moved.
Representative Potter. Representative Porter is making the motion. Representative Del
Second.
Duce is seconding it. All those in favor indicate by saying aye.
Aye.
The motion passes. We are adjourned, and I now turn it back to Representative Gilchrist. Representative Gilchrist, are you there? Senator Lesser? Representative Case, you're still on? Would you like to adjourn the meeting, sir? I don't think anybody else stayed on.
If
you
I
would
can,
call
I
Human
move,
Resources-
I move.
Human
I move
Services
to the
Committee to order.
Human Services to adjourn.
Second.
Bring them back to order. Thank you, Madam Chair.
I second.
We move to recess or to adjourn.
To adjourn. So moved.
Second.
Human Resources Services is adjourned.
Thank you.
Everybody have a great weekend.
Bye, everybody.